Good morning. How are you? Great to see you. I've seen a number of you before, so it's good to see you again. I thought I'd begin by telling a story and sharing a dream. In 1977, I was a brand new pediatric resident at Stanford, and I was at a hospital in Santa Clara Valley on the pediatric ward, learning how to be a pediatrician. And I came to work in the morning, and the nurse told me, well, there's a little girl in room 10, and she's having a lot of belly pain, and she is a little bit feverish and has an elevated white blood cell count. And so I said, well, I'll run right in and see her. And I went in, and this beautiful seventh grader was really in pain. And we talked about what was going on. She indicated she had belly pain. I did an examination, and I found rebound tenderness in the right lower quadrant. And as a brand new resident, you're just amazed that maybe you'll actually make a diagnosis. You'll actually get it right. And I was convinced that she had an acute appendix. So we called the surgeons, and they came and said, well, we're not entirely sure. We'll come back in 12 hours. And over 3 days, they came back and back and back. And finally, she became septic and would have died without intensive care to deal with a ruptured appendix. Now, can anybody tell me what her problem was apart from appendicitis? Can you just guess what the problem was? Sir, what do you think her problem was? She had Down syndrome. That was 1977. And because she had Down syndrome, she might have died. And that's not okay. And I think we're better off today. I don't think that would happen again. But that was an ethical and moral injury done to somebody who was an innocent human being. And that made me really angry. And it partly helped define what I would do in my life. So I want to tell you a dream. I have this dream, and it's maybe 10 or 20 years from now, and a physician will come into the room of new parents, and he'll say, I understand. Hi, I'm Dr. Smith. I'm a pediatrician, and I wanted to just give you a little update on your child's situation. I think you probably have heard that your little girl has Down syndrome. And I know that you're worried about that. You're not sure what to think about there. There's uncertainty. And maybe you've heard from random sources that that is just such a huge problem. But I'm here to tell you that you have a beautiful daughter, and that because of advances in medicine and advances in research over the last several decades, I can assure you she will leave the hospital well. She will join your family and transform it through her wonderful personality. She will have friends, she'll go to school, she'll do well in school, she'll be mainstreamed. She may go to college. She may live independently. She'll have a boyfriend. She'll live a good and rich life. And oh, by the way, I thought I'd tell you, she won't get Alzheimer's disease. That's realistic. I think we're on the verge of a completely new era in understanding and treating Down syndrome. And my colleagues and I are committed to that. And we're not turning back. And we're not saying no. We're going to go forward with that. So there are lots of things that we have to do. We're far from being able to realize that dream today, but we're on our way. And we need you to be part of that dream with us, because if you're not with us, it won't happen. Through time, over the last many years, the families of people with Down syndrome are the people who've made the difference in their lives. They brought them home where they could grow and learn and develop. They got them into school where they could learn and have friends. they're demanding that their kids have the same quality of medical care as other kids. How many of you would love to have an adult Down syndrome clinic focused on just the medical problems that people with Down syndrome have? How many of you want to? Well, there you go. So I'm going to introduce you to Chad Osborne, who's from family medicine, who's engaging with us and potentially creating, I saw 20 hands. Yeah. You counted fast. And so we want to have UCSD be the place where you can bring your loved one for all the medical care they need. And by the way, we have a neurology clinic already, and Dr. Surya Lopez and I run that clinic. We're delighted to see you, but it's more than neurology. We all know that. There are a lot of health challenges in Down syndrome. Let me briefly speak to that. When we think about those health challenges, we look at this list. There's a long list, but let me just focus for this meeting on the upper left-hand corner. There are neurodevelopmental challenges, and we're learning about how to manage those neurodevelopmental challenges and to understand what it is about the developing brain that causes issues when you have an extra copy of chromosome 21. We'll mostly talk today about Alzheimer's disease. And you'll know that that's sitting there on your horizon, and it's a gray cloud, and it doesn't feel good, especially after all the work that you've done already to bring your loved ones to the great state that they're in the moment. So adults with Down syndrome experience a number of clinical challenges. Changes in brain function are frequent, leading to evaluation in the neurology clinic, including the one here. Clinicians with experience in the management of adults with Down syndrome are aware of a number of conditions that can impact learning and memory and mood and brain function, and they then turn to physicians who care for folks with Down syndrome to help define the problems and their solutions. And in so doing, we all, as clinicians, have to carefully consider all the possible causes of neurologic dysfunction, which are many. What about research? Well, there are lots of research advances. I would argue that there's an exponential increase in the interest in Down syndrome and in the understanding of how it impacts the brain. Especially noteworthy then are those changes, are those studies that have looked at the developing and aging nervous system. We're learning how the brain's formed, how it functions, and how it ages. The increasing pace of discovery brings with it the possibility of effective treatments to counteract these disorders. And an important, really important insight is that an extra copy of some genes has a demonstrable impact on the aging of their brain. As mentioned by Ani, the risk of Alzheimer's and Down syndrome is greater than 90% over age 65. But recent studies are really defining the biology of this condition, and the clinical and pathological findings are similar to those in sporadic AD and genetically determined AD. We're learning about biomarkers that help us understand where the disease progression stands without having to do invasive tests, blood biomarkers, for example. And I wanted to point out that an extra copy of the gene for APP is necessary for Alzheimer's disease in Down syndrome, and that data converges on studies in mice that show the same thing. Let me make this very clear. There have been several cases, not very many, in which a person lived into old age with Down syndrome without any evidence of Alzheimer's disease. Those people had the normal 2 copies of APP, not the 3 copies that typically come with a full chromosome 21. In other words, they had a part of that extra chromosome, but not the whole chromosome. And they were missing out that copy of APP. So the bottom line here is that an extra copy of that gene is important. And what does it do? As Ani was saying, it makes this protein called APP. Thank you very much. That's an act of empathy and compassion right there. Thank you. It makes this protein called APP that you're seeing here in the middle of the diagram. Here's the beginning of the protein. Here's the end of the protein. Here's outside the cell. Here's inside the cell. And that protein is to cut into several pieces. And one of those pieces is called C99, and the other is called A beta 42. We know now from our studies that both of them have a very important role in compromising the function of neurons in brain. And you've already mentioned that we've already heard that these plaques, these neuritic plaques, contain this protein called A beta 42. Treatments that target APP then may lead to the ability to lessen the impact and possibly prevent it. And we in our lab have already looked at this, I think, quite carefully. So you'll remember that there are genes in your nucleus, in your DNA, that make a thing called RNA, that in turn make protein, that are in turn turned into protein products that have actions. So when it comes to APP, there's the APP gene, the APP RNA, the APP protein, these two molecules called A beta 42 and C99, and then finally, there's AD and Down syndrome. And we know now in animal models that we can reduce the level of the RNA with an APP, so-called ASO, that we can reduce the level of the protein with a small molecule called posifin, that we can truncate and reduce the levels of A beta 42 with something called a gamma secretase modulator, and that immune-based approaches also have an impact in animal models. So I leave you with the very real hope that we can have treatments to prevent Alzheimer's and Down syndrome. Now, importantly, clinical trials are underway, and Dr. Shiley-Marcos may speak to that briefly. Participation in clinical trials is an important means by which to ensure that new treatments are proven effective and safe. And we really need you then to be aware of the need for working with us to understand better the biology of Down syndrome and to better acquaint yourself with the possibilities of directly contributing to advances in Down syndrome through participation in clinical trials. And now we'd like to move this forward, but I'm having trouble. Let me try this. There we go. So I'm very happy to introduce the speakers today. You've heard from Ani already, but I'll mention that she's just such a delight to work with. She, because of her experience with Down syndrome, is in our clinic, very helpful, speaks to families and encourages them to link up with us here at UC San Diego. Dr. Shiley-Marcos is the co-director with me of the UCSD Adult Down Syndrome Clinic, the neurology clinic. He'll be speaking. Hiri Meharena will be speaking. He's a neuroscientist here at UCSD, and he'll be speaking about his really exciting work in the developing brain. And we have Martha Ranon, and I don't know Martha, but there she is, who's the Executive Vice President of Southern Caregiver Resource Center. Again, Ani and Maggie Shinkata, who's really a great friend in the advancement office here at UC San Diego. And so with that, I think I'll stop and we'll turn it back over to our speakers. And I'm going to try to get myself out of this if I can. Great.
If we could have all of our panelists come sit in the front, and we will ask you each to introduce yourself and how you became involved in this field. And once the introductions are complete, we have some questions that have already been gathered from the audience. And we'll, after introductions, move to the questions.
Good morning. Can everybody hear me okay? Thank you so much for being here. I think this is such an important conversation. It's really a pleasure to be a part of it. And The organization that I represent is Southern Caregiver Resource Center. And if you haven't heard about our organization, we focus on the family caregiver. So those of you who are here because you care, you are a relative of a friend of someone who might need assistance on a daily basis, we are here to support you. Now, what you might not know is that we also started an organization very recently, about a year and a half ago, called CALI, and it's Connections for Adults Living Independently. And the focus is to provide support and care to those individuals living with Down syndrome as among a population. So I am very happy to tell you more about it, but I think for now I'll pass on the mic.
Thank you. Good morning, everybody. Thank you for being here. We're very happy to share with you information about who we are and what's possible now. So my name is Jose Soria. I'm a practicing neurologist by training. I came into the field and became interested in the field while doing neurology, while treating patients in the clinic, particularly because of an interest in memory and thinking. And from there, I noticed that there were groups of patients, there were families that were not always receiving the information that they wanted, that they needed. I noticed that there were groups of patients that are not being served, that are not being attended to. And I thought that it would be very valuable if I could contribute, if I can make a difference. And that's why I do what I do in clinic. And that's where my interest came from serving. So I'll tell you more, but in the meantime, I'll
Thank you. Good morning, everyone. My name is Hirui. I'm a professor of neurobiology here at UCSD. My lab focuses on understanding the molecular mechanism. So we do basic science research. We utilize human-derived stem cells to generate mini brains and different cell types of the brain, trying to understand how that extra chromosome impacts development, Alzheimer's disease. And I'm happy to talk a lot about the work that we're doing, but we have a bunch of exciting things in the pipeline in relation to improving cognition and memory.
Let me go down the list backwards, maybe. So here, what are the most important challenges you face in your work? Is it model systems? Is it insights into the biology? Is it funding? What are the things that are challenging for you?
That's a really great question. I guess all elements that you just mentioned are quite challenging. Funding for Down syndrome had been a very challenging avenue, trying to get research funding. With the start of the Include program at NIH, though, some of that has been alleviated. We've worked closely with philanthropy institutions that have supported our research. That's one element. The other element is also getting enough cohort samples so that we can do our studies of basic science research. So we need, paternal, maternal controls, as well as self-advocate samples so that we can generate stem cells and generate all the different cell types. And we've been working with clinicians very closely here in San Diego, as well as across the country. So we've been making progress, and we've been hosting a lot of events like this that allow us to do engagement and also share what we're doing so that individuals who are interested can participate in our research programs. I think that's...
When I started in research in Down syndrome, I was encouraged not to, because they said it's really too complicated. It's really too hard to study, and you can't do anything. The damage is done. And I'm happy to say that none of those statements is true. It's not too complicated. It's not too late. It's not too difficult to study. So, Harry, think about this for just a minute. Do you think that in time one will be able to chart those molecular pathways that are most important for compromising brain growth?
Yes, I think with the advancement of technology, so we have next generation technology that allows us to explore your entire genome at the same time from multiple different cells at very super high resolution. So we can take one cell at a time and try to understand what is happening as a consequence of trisomy 21. Also, our field has progressed in terms of like technologies looking at how the nucleus itself is organized. One of the biggest findings that we've made so far is if you think of the nucleus as an elevator and all of us have 23 pairs of chromosomes in there, one of the questions we have tried to address is what happens to all of those individuals within that elevator if we try to add an additional person, which would be your trisomy 21 chromosome. So what we found is every chromosome sort of moves around a little to accommodate that additional chromosome, which then generates genome-wide changes, right? Previously, with technologies being limited, we used to think only about the genes on chromosome 21, but now we're actually thinking of the whole system holistically. So technology has allowed us to explore things that were previously not even imaginable. With that advancement, we've now sort of started looking into pathways, specific pathways that we can target therapeutically. And we have certain things in the pipeline. We're not ready yet, but I think it's very promising.
Ani, we need to get to you about the perspective of a family member.
Oh. Well, I just have a lot of fear around it. It's scary to think that my brother might lose his memory and not be the same person he is anymore. So this brings me so much hope, hearing you guys talk about how we're gonna tackle this. And yeah, it's beautiful. Thank you so much.
I mean, if we don't have our hearts open to the families, the motivation isn't what it needs to be. And I'm going to ask Jose to talk about our experience in clinic, but when we're in clinic, we're often confronted by families that say, there's just something different recently. My son or my daughter, or my sister, my brother were the life of the party. They just had such a bright personality. Everybody wanted to be around them. But Doc, it's changing. I don't know what's happening, but they're not so interested in that anymore. They spend way too much time in their room. And sometimes I hear them talking, and the self-talk, which is normal, it's turned negative. And I don't know what's going on. And then they say to Dr. Surya Lopez, do they have Alzheimer's disease?
Thank you, Dr. Mobley, for illustrating that example, and that's exactly what we see. I want to share with you some of my initial impressions when I first came into the field, and a number of years ago we started seeing more patients, and what that experience is like, and the need for research, and how to ask the right questions and hopefully get answers. As a family member, you might wonder, we've had questions about, what's the best way to contribute, if there are ways to participate in research, or clinically, at which point is there a need for a higher level of care clinically? And so the answer in some ways comes from the heterogeneity. So how different patients in clinic can be. So we have a more typical experience of what we think the reports are from family and patient. But in some ways, the challenge has been, when it comes to research, is trying to capture within Down syndrome, within that experience, the breadth of how somebody could present. So when somebody is coming to the clinic in their 20s, their 30s, their 40s, we have an idea about how the biology should be changing, and you've seen that today. But as a family member, you're wondering, how is it that what I see at home, the changes that I'm seeing, how could knowing about those changes help you in research? And the answer has to do with heterogeneity. Humans, by definition, we're very heterogeneous, we're very different. And we're trying to understand that heterogeneity and how it matches what is happening biologically. And having enough breadth of the changes that are happening, when they happen in different families, different patients, that's what I believe will allow the translation of the new discoveries and the findings to make it into the kinds of treatments we hope to have in clinic. So in some ways, it really is sharing that experience, those changes that happen in clinic, the way they're followed and monitored in clinical research. That contribution is what makes the being able to understand the biology possible. Without the clinical context, we don't always know what the biological changes mean. So yes, we know about amyloid, and yes, we know about the changes that do happen at the level of the brain, the synapses, but it's matching that understanding to what you see at home, matching that understanding to when you see it, how you see it, that will allow us to then translate the biology. And in the office, the questions that we get typically do include, is this a sign of a progressive, relentless, constant decline? The answer is not always yes. I'll start by saying that many times the answer is not necessarily that your loved one is experiencing Alzheimer's disease. There are many things that can affect a patient that are not related always to amyloid. And we want to know, you want to know that answer. We need to know, of course. There can be changes in behavior, mood, demeanor that relate to a recent experience the person had. So it doesn't always mean that there is a progressive biological change. But even if it doesn't mean that there is a change, we do want to know that. We want to know that in clinical research. We want to know what is normal, what isn't, at which point it matches a biological change. So it's capturing that experience, that diversity of experience that will allow us to move the field forward. And is by participating in research and contributing that experience, it matters. It does add to the story. And so I want to encourage you to and empower you to say, yes, my experience matters. What I see at home matters. Even if it doesn't mean that there's a biological change, we need to be able to document it and measure it over time.
Thank you. I'm really glad that you mentioned that, that really the first line of awareness being the family, because it helps the researchers, it helps the people who are working directly. I want to empower all of you who are family caregivers to really try to educate yourselves as much as possible with what you are facing at Southern Caregiver Resource Center, and of course now with Callie. That is one of our goals in talking about our challenge, is that many times families don't know what they don't know. And so therefore they don't even know where to begin. And so we want to be able to walk with you through this journey to help you and connect with you and, provide you the resources that you need, but also that support, that emotional support that sometimes, behind every person with Down syndrome in this case, there is a family member behind that individual or a friend. And so we want to make sure that there's this holistic approach to supporting the families. You can work directly with the person, the individual that needs the care, and we can work directly with the family caregivers to support them. And now it's a partnership of collaboration to try to find the best support.
Caregiver support system, people with cancer. What are the elements of that? What does it look like? Are we there? No.
Well, I wouldn't use the word perfect because it's always evolving, but in an ideal situation, it would be a family member really wanting to know more, trying to get more education on what they are looking at, the diagnosis, the long-term plans for care, for treatment, maybe from some innovative programs, clinical trials, But I do think that, especially all of you who are here, you are very curious. Staying curious is key, because that's how innovation happens, right? That's how you are able to arrive at different conclusions. Where the populations that we work with, all of San Diego and Imperial counties, we know that sometimes family members really don't know where to begin. So that is the challenge for us. We don't expect you to say, my loved one has, beta amyloid, of course not. But you know the changes that are happening in those individuals. You see the progression, and that is key to not only the treatment, but also for the support. So I do think that it's manageable. We can do this. It's just, it's not always easy. There's a lot of education that needs to go, and that's why we're here. My colleague, has a booth on the outside here with more information, with resources to support you.
For us, I want to say being, in collaboration with families and clinicians has drastically changed the way that we do research. So fundamentally, as researchers, we have an inclination to dive into the nitty-gritty stuff and then get excited about those things. About 8 years ago, we sort of formed a partnership with clinicians and families. So since then, I think even the quality of the work that we do and the impact of the work that we do has significantly changed because of your input. So for us, we have partnerships with different associations of individuals with Down syndrome. And during those times, we have these collaborative discussions where families can tell us what is most important to them today, what they've noticed throughout the lifetime of the individuals that are living with Down syndrome, and the self-advocates, what is important to them. That allows us to sort of design the projects that would be most impactful to the individuals living with Down syndrome. So I want to encourage you all to always feel empowered to share what you think is important, because that is our guiding, avenue.
And I'd like to second that, of course. I would like to have a system where we would come together as individual families or groups of families, and we discuss those things that are the most challenging for us. Where do we get care? How do we get care? What do I need to worry about? What can I do that will help my son or daughter, brother, sister? And then have an answer to that, and have a ready, if you will, pipeline of people to talk to engage, to help you answer these questions, to support then not only the clinical care of your loved one, but of others with Down syndrome, and to have a kind of connectivity between the clinic and the clinical trial and the research lab that really brings value to every family that's part of it. Jose and I are notorious for listening when families come in and talk about, their brother, sister, son, daughter. And we have to do that. I don't think a lot of people are really high on medical professionals right now for how well they listen. If I asked for how many hands, it wouldn't be very many. But if I asked for the number of hands of people that would like their doctor to listen to them, my guess is most of you would. I sure would. It's hard. Our clinic is one where we aim to first listen without guessing anything at all. Just listen to what the family's saying. Let them talk. Turns out that doctors typically interrupt the patient after 13 seconds. It turns out you don't actually have to wait much more than 40 seconds to convince the patient that you actually care. Well, I think we're waiting for 5 minutes. I mean, we go a really long time. We're definitely overachievers in listening. And the reason that we do is that if we can't hear what you're feeling, we can't feel with you. And if we can't feel with you, we don't know what to do for you. That's just a fact. We can guess what you're feeling. We can guess the right thing for you. We can't know it until we hear how you feel and we share your concern, really share it, and emotionally share it. And I'm aware that that's challenging, but we have to do that because we owe that to you. If we do listen to you, if you believe that you've been heard, then there will be trust. And if there's trust, you'll come back and you'll want to be with us again, and you'll trust us to care for you and your loved one. And that will bring a very different connectivity with professionals who study the disorder and who do research and who do clinical trials. I think without trust, we don't make much progress.
That was an excellent transition. Speaking of interrupting and listening, I would like to move us towards audience questions because I have seen a lot of interest both before the program and during this talk for participant questions. And I'm sure that there will be many more than we can fit in today's program. So please, after the formal agenda, feel free to come up and ask the panelists questions, as well as all of the resource table vendors will also have good answers and services that they provide to the community.
Okay. Is there an ideal age to start clinical trials? Is there an age that is too old to start a trial? Jose.
It's a very important question. And I'm going to put myself in your shoes, the person asking the question, and that comes from a place of curiosity, but also vigilance as well, clinically. So as of now, I'll give you two answers. So as of now, it's never too early and it's never too late to be interested in clinical research and participate in clinical trials. Because again, it goes back to this idea that there is a heterogeneity, a diversity in the patient experience that we cannot yet measure biologically. So we're constantly trying to gather how the person is changing, how old they are, and then going back and matching to the biology you saw earlier and saying, okay, would a medication work for this symptom? So you don't want to restrict what you have to offer. I'll start by saying that for research in general, just to be clear. There are clinical trials now happening. I'll just mention three names as a reference, but there are trials. There's a trial called HERO that has been happening recently. It's with a medication that's an antisense oligonucleotide. You might have seen the chart earlier. Medication. There's another trial that uses the medication all the way to the right in the diagram that you saw. A monoclonal antibodies a trial called Aladdin, like the movie. And there's another trial called ABATE, which is a vaccine trial essentially. And for those trials, typically the age group does not tend to be very, very young or very, very late. So that's closer to the middle. You're essentially typically looking at age ranges in their 40s and 50s, maybe after 35 or so. But that should not discourage you from asking questions and being interested outside of that age range. And we would not want to, at this point, set a limit because medications, as they will come through the pipeline, you don't know what you don't know. So we're not yet convinced that we know exactly the age group that should be treated. There are medications that do treatment, medications that do prevention, and there's something called secondary and primary prevention. So there are going to be, our hope and the dream is that we're essentially looking at prevention altogether. So please don't hold back based on age. I hope that answers the question.
Let me stay with you, Jose,
Yeah.
a little bit. So this is regarding, let's say, a clinical trial that they may want to participate in. Will they know the risks before they decide to participate?
That's a great question, Dr. Mobley. So would patients know risk before they decide to participate? As as you would typically see in yourself when you go to the doctor, you wonder, doctor, is there a risk to the medication, a side effect? And the doctor's probably going to say yes. But so the answer is yes. Every clinical trial would be able to disclose any adverse events or risk of adverse events leading up to the participation. So typically, the way this goes is, and this is in all kinds of clinical trials, that there is an interview, there's some form of evaluation about the baseline information about the individual. There's a screening process where a person will be evaluated whether or not they're candidates to participate in this study. There are trials that are used medications. There are studies that are given actively a medication or not given a medication. There are studies that have other kinds of interventions. It's not always a medication. There are studies where we monitor symptoms and do not give a medication. But if there's a medication, yes, there would be extensive conversation about the side effects, and it is what's called informed consent. So absolutely, there is a regulatory body behind this that absolutely requires that level of disclosure. And so you would never participate or take a medication or not take a medication, not knowing the risk.
Good. Let me ask Hiri a question, if we could. Hiri, do people with Down syndrome age more quickly than the general population?
So
You're a good person to answer this one, Hiri.
yes. So how many of you have heard of epigenetics? So epigenetics is basically taking your DNA and making some modifications on it that changes how it's accessible, let's say. So what we know is there's this modification that happens called DNA methylation. And as we age, that sort of deteriorates with time. And studies looking at the rate of that deterioration in individuals with Down syndrome is highly, is more pronounced. So there is sort of epigenetic aging in general at the molecular level. So that's the sort of studies that we do.
Great. Let me go back to Jose for a couple of questions. These have to do with clinical trials. So I guess the most important question is, what's in it for me? Why would I? Look, it's a lot of work being involved in a clinical trial, and many trips to the clinic and lots of things that are going to go on. I mean, what's in it for me?
So I'll speak from the experience that we've had in clinic and also seeing patients go through clinical trials. I'll speak at a large scale. So if you have 1,000 individuals that you know that are friends of you, friends of the family, and maybe 1,000 have participated in clinical trials and 1,000 have not. Typically, the most obvious shift when a person participates in clinical trials is, practically speaking, how well informed the person is. So by definition, by the time you are here today, by the time you decide to engage in a conversation about screening, that's already a level of knowledge that you have, the involvement, the relationship with the center that's doing the trial. That's really above and beyond what typically would be only available on a clinical basis. So the relationship with the center that's offering the trial, even going through the evaluation, whether or not you qualify for the trial, that already, in my experience, essentially allows for a level of knowledge, involvement that will carry on. It's not as if you do the screening for the clinical trial and the center disappears. We will be here. We're not going away at all. So that relationship, I think, is important. And then, so number two, so many times when there's a trial, for example, there's a clinical trial, there's many questions about 2 or 3 things, as Dr. Mobley mentioned. So what's in it for me because of the level of involvement? What kind of benefits do I get for the level of energy that goes into attending? Two things that come up to mind. So typically, you want to know in a trial what's happening, if you're being randomized to medication or not, or if you're being evaluated, how long the trial is, but also whether there is an opportunity. And this part is very important. It applies to a lot of trials. After the trial is done, or right after, there's this period of randomization where you don't know if you're taking the medication, if there's an opportunity for open label. And we're going a little bit into details here, but it has to do with whether or not at some point there's the possibility to access the medication, the investigational product knowingly. And that it turns out to be relevant now at the time that we're in, because we're at an inflection point where I see the trials that are happening now and soon to come to be the kinds of trials, particularly when they are in more advanced phases, of medications that will, I foresee, and I have the dream as well as Dr. Mobley, that they will be available at some point approved for use. So being in a trial at this point essentially would allow you, it's not a guarantee, but to be taking a compound or a medication, investigational product that at some point would become available to you in an open label basis. So you're essentially in the future, you're living in the future ahead of time. So that to me, that's the most obvious part. And I have these conversations with patients readily. And then the second part of this is that without your participation in trials, I mean, this is no secret. Without the participation in trial, there simply cannot be progress. Without capturing the breadth of diversity of what you bring to the table, we don't know how well a person does. The regulatory bodies, the governmental, the federal regulatory bodies around this would not know otherwise. So you are making it happen for everybody for generations to come. And that's just a reality. So I'm glad that you're here today. So thank you.
Martha, let me get you involved. Why is it taking this is the question now. Why is it taking my loved one with Down syndrome more time to do everything now?
What is it?
Why is it taking my loved one with Down syndrome more time to do everything now?
So I've noticed that with caregivers that we work with, there is a lot in terms of knowing the signs of Alzheimer's, dementia, right? And so people are very used to memory loss or lack of vocabulary. But when it comes to individuals with Down syndrome, it is really behavioral and it's very different. And so families, like you were saying earlier, really are the biggest advocates for these individuals because they know them best, right? So you know how they react to certain things or how they would take certain pieces of information. And so I think that that's why it's really important that when you do start noticing these changes, that you talk to your medical providers, that you reach out to organizations. I mean, you are, I think, a wealth of information here that families can talk to because there is going to be some change, right? Life is change. That is what life is. And so if we notice certain changes in us, we are definitely going to see some changes in the individuals we care for. So it's always good to ask, and don't be afraid to ask. There are no, questions that do not glean any information. I think all of the questions are valuable. So I encourage families to ask those questions.
Carrie, let's talk about the research a little bit more. I'm going to ask you two questions. How do model systems teach us about the neuroscience of Down syndrome and aging?
That's a great question. So currently there are two very strong models in studying Down syndrome. One is utilizing mouse models. So we have different types of mouse models where they have an extra chromosome that mimics the genes on chromosome 21. And then we use human-derived, skin cells or blood cells to generate, stem cells that would allow us to generate any type of cell from the human body. So the stem cell model is quite powerful because we can, one, do a large number of individuals simultaneously, which increases the power of the data that we're going to generate. And second, it also allows us to explore different time points within development, for example. So when we reverse them back to stem cells, they go back to when the embryo began, and then we can just follow the whole progression, which allows us to see how the brain differentiates from one step to the next, and we can make these little mini brains inside a dish, and we can follow them through time. And we can see how the neurons fire, how they're connected, many studies that we can do. And we can also age these models. So we can look at Alzheimer's pathology, how amyloid plaques form and how they lead to neurodegeneration. So there's a lot of models that we can utilize. And recently, we've now developed technologies that would allow us to merge the two. So we can take human cells and implant them into mice. That would give us a more physiologically relevant sort of model. And in those models, we can study behavior. So, what are the differences between neurons that have 3 chromosome 21s versus 2, and how does that alter the mouse's behavior? Yes, it's not human-specific behavior, but they could allow us to get more insight into some of the differences between neurotypical individuals and individuals with Down syndrome.
Okay, so here you did a lot of work, and you were, I think you now understood something about a particular pathway. You identified that pathway is really abnormal in the context of trisomy 21. But how do you then develop a treatment for that? I mean, is that just knowledge for knowledge's sake, or does that make it possible now for you to develop a treatment?
So I can share a few experiments that I did my group did in the last couple of weeks. And we just got the data, so this is very exciting data for us. We wanted to understand why during neurodevelopment, it's sort of like individual with Down syndrome have a deviated sort of neurodevelopmental pathway. So we took blood samples from individuals with Down syndrome and their either parental controls or sibling controls, and we made the early neural cell types, and we looked at what happens to them in time. So for the longest part, we always used to study Down syndrome at one time point, but there was a bunch of indications maybe we should be looking at what's happening throughout the whole day. So we collected samples every 6 hours for 24 hours and tried to understand if there are any differences. And interestingly, what we find is if we start at 6 a.m. in the morning, what we find is that the 6 p.m. samples is where there's a lot of cell division, and that system, for whatever reason, does not kick in fully in individuals with Down syndrome. So we devised new therapeutic interventions that we hypothesized may potentially work. So we treated those neuroprogenitor cells with those combination of drugs, and we find that at 12 hours now we can boost that proliferation. So now we would take what we've first done in human stem cells in a dish, then we can take them into a mouse and try to see if we can treat the mom and a pregnant mouse mom. Then we can try to see if we can alleviate the neurodevelopmental abnormalities that are seen in that mouse model, as well as later in life, learning and memory, contexts. So we can basically take it through the whole pipeline and get it to the mouse. Then we would engage somebody like Bill to help us transition that into more clinical trial settings. So this is why basic research can be translational, starting with samples derived from families. We take it into our labs, do our studies, develop some new therapies, and then we partner back with clinicians to try to see if we can do some clinical trials as well.
That's great. Let me go to Jose again. Jose, what are the 3 questions that families ought to ask you when they come to our clinic?
I'll give, so the 3 questions a family should ask us coming with your loved one to clinic. And I'll answer that by referring back to what we've seen in clinic, the experience that Bill and I have. Typically, that revolves around the questions. As we see families, I'll answer in 2 parts. So as we see families over year after year, typically the family would ask, what is it that I should have known when I first came to see you? What is it that I should have been asking? What should I have considered important? And it's a combination of clinical or social component, but the question is, is there something that I could be doing for my loved one to help them maintain their independence, their level of functioning? And if so, what is that? So I think that's most important, because that gets to the question of what is happening beyond whether or not is related to Alzheimer's disease. And there could be a number of things happening impeding their level of independence, the level of function. And 2 is, regarding safety. Sometimes we don't always acknowledge that the reason that we're in clinic is because we have some level of concern about safety for our loved ones. So the second question would be, what are the kinds of measures that I should be taking? And there are many reasons why people see us in clinic, but just summarizing, what are the kinds of measures that should be taken to maintain safety at home? Am I missing somebody? And the answer is not always related to a tablet, to a medication, to a pill. Sometimes the answer has to do with the level of support that's needed, the social support. And so that it's a broad question on purpose because you don't know the answer ahead of time. You might not know what the clinician is going to say. It might be an amyloid targeting agent, or it might be, a measure about breathing or about swallowing or about falls. And then the last question typically has to do with prognosis and plan of care. So that last question, question number 3 is, what is the plan of care long-term here? You've had this conversation with me today. You've answered my concerns today, but what is the plan of care going forward? What do you foresee the next visits are going to be like? And what are the kinds of things you're looking forward to checking as I come back to see you later on? So just making sure there is a plan of care, a continuity of care, because as Bill mentioned, is that longitudinal relationship and the trust that would matter the most. If you only see the clinician once, then it's a little more difficult to have that relationship. But making it clear to the clinician and the team that you want to be able to see them and you're looking forward to what the plan of care is going to be.
Martha, let me ask you this question. What signs of Alzheimer's should we watch for in a person with an intellectual disability?
Definitely, I think we've mentioned the changes in mood and behavior. That is very important. If the person that you knew used to be a certain way and now they're acting very differently in social settings or maybe withdrawing, that definitely is something to further explore, talking to your physicians, your healthcare providers. But also their level of abilities to do the things that they used to do. We know that just typically, as we age, it becomes more difficult to go up the stairs or run or do anything like that. And those are changes in and of themselves. But I think with a person with Down syndrome is definitely noticing, are they having a more difficult time taking care of their needs? And so that is why it's important that if you do need that extra assistance, that you connect with resources that can help you do that. Sometimes you might not be able to help them, let's say bathing or doing the things that they need to do, but then you can solicit the assistance from someone else who can help you with those activities of daily living. It is really important. You were mentioning safety in the home. That is definitely a key change that needs to be modified. If you're noticing that they maybe are tripping more because they cannot gauge the different maybe contrasting colors in where the threshold is to the door versus the carpet that they were stepping on. Or maybe going into the bathroom. I mean, what color is the bathroom usually, right? The toilet. What color is it usually? White. What color is the floor? White. What color is the wall? White. Now everything looks white. Where is it where you sit? And so maybe lighting, it needs to be added or increased. Maybe contrasting colors, removing mats that are going to add to the trip hazards. Those are all things that as family members, caregivers, friends, that we can maybe assess. And we do talk a lot about that at our organization. So feel free to reach out and we can talk to you about how to modify your home to help you with that.
Jose, 2 questions related. Well, what age should we start thinking about Alzheimer's and Down syndrome? And by the way, how do you diagnose it?
So and thinking about when you're visiting the doctor and what is the sense of urgency? What are the time sensitivities you want to, and I'm assuming, Bill, the question comes from planning, should we have a time schedule in our minds of the kinds of times that we should be coming into the doctor and being followed. Um, I want to point out that when we think in the clinic, just broadly about cognitive decline, we don't always want to narrow ourselves to a cognitive decline that relates to one disease or diagnosis. So we don't come into clinic to be diagnosed with one disease. We come into clinic because of a cognitive change, and that can happen at any time. I mean, we've seen many patients that in their 20s and in their 18, 19, 20. So if you see a cognitive decline or a change in behavior, in mood and demeanor that is significant enough to interfere with function, you do want to be evaluated, even if your loved one is 18, 19, 25, because there are a number of things that can change in somebody's lives and it can be affecting them. I'll just give an example. There can be medical changes happening to a patient affecting their cognition. And we don't want to say, oh, I'm going to wait because Dr. Soria mentioned that it is in this age group that I should be asking the question. So always just going back to saying, okay, if there is a change, I'm going to see the doctor. There's a question that has to be addressed about cognitive decline or change. Now, if you are considering specifically cognitive changes related to Alzheimer's disease, you're wondering, when should I be thinking more that, perhaps these changes that I'm seeing are more concerning for Alzheimer's disease? And the answer to that, you're going to see epidemiological data out there if you research the information on the internet. But I'll tell you what we see in clinic. And that's more, the time that we begin to consider more closely is in your 40s, mid to late 40s, early 50s. That would be more likely what you'll see in clinic. And that age group, and definitely in your 50s, early 50s, at that point, it would become more relevant. But you don't want to separate the patient from the disease. You're really treating the patient. You're not treating amyloid, you're treating the patient. And the patient's cognitive changes can happen as a result of a conglomerate groups of things happening. Hearing loss, lack of sleep, head trauma, medications. Now to the question, Bill, of diagnoses. So the diagnosis of Alzheimer's disease, as of now, as we stand right now, is still a clinical diagnosis. We cannot yet send you a packet in the mail and say, take this one test and we'll know the answer to the universe. It's still not there yet. It's still a very clinical endeavor. It might be like that one day, but we're not there yet. We have testing that can support the diagnosis, but it's clinical. And it is based on listening. And thank you, Bill, for pointing this out earlier. So it is really listening to the story, what has changed, the pattern of change, particularly when there's a loss. Typically what you would hear is a loss of their routines. A person would have fixed routines that they know how to do very well, people that they would typically recognize very well, places that they would be very familiar. And in Alzheimer's disease, there's a tendency to lose those skills. So loss of skills, loss of their routines, loss of facial recognition, definitely short-term memory loss. And yes, it can present many times with behavioral changes, but it requires the patience and the time to ask the questions, to listen. If we try to guess what your answer is going to be, we're going to get it wrong. So we do have to listen. And it's clinical diagnosis. And yes, we have then subsequent testing that we do to rule out or exclude other competing things that could be causing the symptoms. So yes, there's blood testing. Yes, there's brain imaging. And very soon we're going to have more and more sophisticated testing available, thanks to everything that's happening.
So let's talk about how we in clinic manage symptoms.
In clinic, and so one part of that, inevitably what comes out of a visit like this is, well, what do you do about what you find out? What if you find out that I have daytime drowsiness, Dr. Soria, and maybe that's why I'm not listening. I'm sleepy during the day. So we do manage the symptoms that we find. And I'll start there as an example. So if we take a step back and say, okay, if you have daytime drowsiness, there's a difficulty with sleep, you're not sleeping well at nighttime, there's gasping for air, there's treatment for that. There's treatment for sleep apnea. And I'm going into some examples here that are typical. You do want to make sure that there's a clear medical evaluation for when there's fatigue, drowsiness, low energy for medical conditions. You want to make sure your thyroid is okay. We want to make sure there's not a significant anemia. So there are clear interventions that make a clear difference. If symptoms, when you hear the word symptoms, you might, in Down syndrome, you might be imagining other things like changes in behavior, mood, demeanor. Is there more self-talk? And if so, is it now a different kind of self-talk? Is the person responding to an external stimuli? Is it a voice? Is it an image? Is that person familiar? So yes, there are treatments for symptoms, and that includes medications that help with mood and demeanor. And yes, there are medications that can, of course, take away those external stimuli and sensation. I'll mention two or three other things that I think are important to monitor. So again, when we think of the patient, we want to treat the patient, not one disease. A person has a lot of things they experience. So everything else still matters. For example, hearing, seeing is important. A person needs to be able to hear well and see well to be comfortable. If the person is in pain, that's a problem. And if the person has trouble with balance and falling, and that affects them, is a problem too. So you never want to disconnect the person from the equation. So those are the questions that we're going to ask you in clinic when you come in. We're going to interrogate you. We're not the police or anything. Those are questions that we just need to ask you.
Thank you. I'll answer just a couple of these. Do you see any similarities comparing the Down syndrome regression syndrome and Alzheimer's with respect to the amyloid plaque studies? So who's heard of regression syndrome in the audience? Yeah. If I had asked you that 10 years ago, you probably would have looked at me with a blank stare because we didn't, I think we recognized it, but I don't think we really fully appreciated how common it was and how we had to be alerted on the alert for that. We have folks that come in and say, my young adult daughter was just so functional and again, just really wonderful to be with. And we're not sure what happened, but she changed, and she changed relatively rapidly. And she stopped speaking normally. She's now whispering when she speaks. And she's slower in her thinking. And even her motor, even the way she moves is different. And she seems uninterested in engaging socially in the way that she did before. She's 22 years old. That may be a diagnosis of regression syndrome. We would have to think through it because she could also be depressed. But guess what? Regression syndrome is a real thing. It's very likely mediated by immune changes in the body. It may well be linked to the underlying increased risk for autoimmune disease in people with Down syndrome. Remember that on that chromosome 21, there are also 4 genes that encode receptors for interferon. So when people with Down syndrome have an event that could cause inflammation, it may well be more dramatically manifest in them. There's a very nice diagnostic consideration for regression syndrome that needs to be pursued, but this is a young person. We had a woman from Florida, if you'll remember this, a woman from Florida brought her daughter, Stephanie, to clinic. And the concern was that she had Alzheimer's disease. Was she 18 or, I don't know, very young.
Very young.
20s, definitely, yeah. And she had been told by a neurologist in Florida that she had Alzheimer's disease. She didn't have Alzheimer's disease. You don't make that diagnosis until at least age 40 or even after age 40. And if we had looked at her brain, of course, we did not do the test that would look for amyloid in her brain. It's called a PET scan. We wouldn't have seen it. So she didn't have Alzheimer's disease. She had another condition, which we thought might be a regression syndrome. Ultimately, we decided that it may not have been the diagnosis, but that was a very real consideration in her. There's a very nice trial going on in Los Angeles, at Los Angeles Children's, looking at the efficacy in people diagnosed with regression syndrome who have a clear diagnostic workup, including both imaging studies and EEG, as well as blood work. And they're testing anti-inflammatories to help control the disorder. I don't know, the data's still out there, it still needs to be analyzed. But at least there's now an appreciation of the condition, a way to manage it, certainly a way to diagnose it, and I think ultimately we'll find new ways to manage it. It can be very, very frightening. The family, they say things like, you know, she's just become psychotic overnight. By the way, we always ask the question, when we see people who manifest this, has there been any change at home? Have things changed at all in the family? And with Stephanie, you'll remember that she was bullied at school and became incredibly frightened to go to school, and really, it just completely, emotionally paralyzed her, is what I would say. So we always ask about the home situation because a sibling leaving for college, a grandparent passing on, a beloved grandparent no longer there to be with the person with Down syndrome can elicit quite dramatic changes in behavior. And they're not all regression syndrome, but we need to consider that as a possibility in such folks. So no amyloid, it's not Alzheimer's disease, but it's a real consideration anyway. There's another question about brain fog, say from celiac disease. Are there any similar neuronal degenerative changes akin to the Alzheimer's findings? Not that I'm aware of. Not that I'm aware of. Celiac disease is another autoimmune disease. It can manifest in a number of different ways involving the gut, but can also involve the body systemically. We don't actually see very much of that in clinic, but it's certainly a consideration. But yes, there can be neurological manifestations. I could readily imagine that systemic inflammation could affect brain function, but it wouldn't be the same pathology as Alzheimer's disease. Jose, did you want to say something?
We would not, and I agree with Bill, but we don't, when we think of brain fog or thinking changes, you know, the question of celiac could come up. I can imagine medically there's a way that would come up, but we would not want to, it comes back to the idea that we would not want to narrow down the one cause of the brain fog has to be because of celiac, and if it's not celiac, there is no brain fog. That there's always a need to detach the symptom from the things that we think could be causing the symptom, and there are other things that will be looked at as well. So, but I agree with Bill that we haven't seen necessarily this come up in clinic.
I'll take another one. The question is, how is Down syndrome and Alzheimer's linked on the cellular molecular level? I think it's fair to say that we're learning more and more about this all the time. It's a really interesting thing in Down syndrome that one therapeutic option is to say, can I find a gene whose presence in 3 copies is necessary for a clinical condition? And if I can find that gene, can I just reduce its level of expression to normal? Now, there's no guarantee that that will solve the problem. And it doesn't say that that's the only gene that's important. It does say that gene is necessary in 1 extra copy. And as I mentioned, in the case of Alzheimer's and Down syndrome, APP is necessary. And so our strategy for years has been to say, how can we reduce the level of expression of that gene? And I think that's really going to yield results. But there are other disorders in Down syndrome that seem to be similar. Just this week, a paper was published looking at another gene called HMGN1 that appears to be necessary for the heart lesion, the congenital heart lesion that folks with Down syndrome suffer from. They have a hole in their heart, if you will. And that hole appears to be a failure of proper proliferation of some of the neurons in the developing heart. And that gene, HMGN1, when present in 3 copies, is responsible for that, is necessary for that. And in a mouse model, they were able to show that reducing by 1 the copy of that gene was able to basically prevent the cardiac malformation, or at least the major elements of it. So I think we'll find more examples of that in Down syndrome. And then it brings to fore, how would I really know how to protect people with Down syndrome from a number of conditions? And I think we've not invested enough in the basic biology of the condition so that we can say with some confidence, we can link this gene with this condition. And because we can do that confidently, we can now target that gene for therapy and hopefully in the process, prevent the problem. I think it's a beautiful new future for research in Down syndrome. And I think it applies both to the developing brain and to the aging brain. Kerry, would you like to say something?
No, I think that was perfect. At the beginning, Bill, you mentioned that having a whole extra copy of chromosome 21 makes it very complicated. And I think there are going to be elements where, there's a single gene driving the whole phenotype, but then there are more complex structures that probably are manifesting because there's just homeostatic imbalance because of that, imbalance in number of chromosomes generally. So we're embarking in both sides, and I think there's numerous studies that indicate that there's specific genes that could be targeted for specific diseases. And I think Alzheimer's is the cleanest one because we have human data where there are a few individuals that just lack that third copy of APP and just have no Alzheimer's disease, making it one of the most clearest indicators that APP should be targeted as a therapeutic intervention. And so, reducing the gene itself or the protein product or the A beta is absolutely critical as a therapeutic intervention. And for individuals with Down syndrome, if we could do that, I think that would absolutely change, the perspectives on Alzheimer's disease or DSMD.
Right now, the most common diagnosis at the time of death of a person with Down syndrome is Alzheimer's disease. If you look at aging and Down syndrome, boy, it's changed so much. When I was a little kid, folks with Down syndrome lived on an average, so I don't know, 8 or 9 years old. And now they're living to 60 or beyond. Alzheimer's disease is preventing them from living to a normal old age. A very interesting patient was cared for at UC Irvine. And he was a man, he visited Ira Lott's seminar one day, and he went up to Dr. Lott and he said, "Dr. Lott, I'm sorry I was late. My brother and I have a different philosophy." And Ira was very interested, and they began to talk, and he entered a clinical trial, and he was followed for 8 years. He died at age 76, having had no change in cognition. 76. He had a brain pathology that showed not one amyloid plaque. He had a little tau pathology, but that was just typical for aging. And he had 2 copies, not 3, of APP. So we're living in a time where we now can see the opportunity by preventing Alzheimer's disease from giving people with Down syndrome a rich, full life. And that is absolutely a main focus of ADRC, the work that people do here, the effort they put into all the good things they do. And I know that they really relish the opportunity to get to know this community better and to serve them. Emily, do you want to say more?
No, thank you. It really means a lot to all of us here that you guys have offered your time and expertise this morning. Thank you from the bottom of our hearts. And as all of you know, there are many ways to partner with us. You can get involved in educating yourself and involved with our community partners and accessing their services. You can get involved with research. We have opportunities to be involved with research at every level, from just educational to being followed over time with no intervention, and to be able to donate some of your skin cells to make these model systems that Dr. Meherena talked about. And then there are also, of course, clinical trials. So being a part of our center will give you first access to those opportunities to be in trials. We are also building capacity right now to include Down syndrome as one of the main groups in our clinical core and main focus of our Alzheimer's Disease Center. So I would like, before we close today, to have Maggie from the Advancement Office come up and say a few words about if you'd like to get involved that way. And we'll conclude with final remarks from Anis.
Well, before I begin, I would just really like to thank our speakers and our panel for being here today and for dedicating so much of their time and their research and their resources to Down syndrome. If we could give them one round of applause. And of course, I would like to thank the ADRC for putting on this amazing event this morning to raise awareness for Down syndrome and to include the Down syndrome population in their research and in their cohorts. Well, for those of you who I haven't met yet, my name is Maggie Sincata, and I am an Assistant Director of Development here at UC San Diego. My primary role is bringing in funding for the groundbreaking clinical trials, research, and clinical care that we do here. I'm so excited to be here this morning on behalf of the ADRC and just all the exciting work going on around Down syndrome and really opening their doors to the Down syndrome population and including them more in their research and in their cohorts. As you've heard through today's discussions, we're working on building out the Down syndrome program through the ADRC by recruiting and enrolling more folks in our trials and in our research, as well as bringing in top clinicians and scientists who are experts in this very unique but important field of research. This initiative will closely partner with the Down Syndrome Aging Clinic here at UCSD and potentially the Down Syndrome Primary Care Clinic to really bridge that gap between research and clinical care. However, with this initiative comes a need for additional funding to support our faculty members, our staff members, and the infrastructure around this program. This is where philanthropy can play a huge role. At the moment, one of our funding needs is to fund a program manager for the Down syndrome program. This role will be responsible for a variety of things, but mostly for recruiting and enrolling folks in clinical trials and research trials, for coordinating support groups, and for working with the clinical teams so that not only individuals with Down syndrome, but their families and their loved ones and their caretakers have all of the resources and the support that they need moving forward. Unfortunately, federal funding is limited at the moment, and this is where a private investment could make a world of a difference and really allow this program to grow and to thrive. I am more than happy to speak to anyone who is interested in getting philanthropically involved. I'll be around after this to answer any questions or share any opportunities for how you can get involved and help this program to grow and thrive into what we know it's all capable of. Thank you all for being here today. I really do think that this is the foundation of something that is going to be so great and really a world-class Down syndrome center through the ADRC. So thank you all.